Can we take our seats, please? Thank you very much, everybody. Not too much from me right now. My name's John Mathias. I'm the chairperson of MPN Advocates Network. I will be doing a much more formal introduction and welcome to the conference after our first talk. This talk from Martin, who I'll introduce as well in a second, was originally planned to be a kind of a starter or a kind of getting up to speed with MPNs. We did it 2 years ago and very, very successful. It was supposed to be like an optional talk for anybody who kind of were new to MPNs or needed to learn, etc. And it's turned out to be such a successful talk that we've repeated it a few years now. And I'm sure that one of the main reasons for its success and its popularity, as demonstrated by the fact that nearly all of our delegates are in the room now, is the fact that Martin is such a great speaker. Now, Dr. Ellis, Martin Ellis here, is a specialist MPN hematologist in the, and I'm going to try and say this right, the Meir Medical Center in Tel Aviv. He's a genuinely world-class MPN specialist and is the ideal person to get us started this morning and to give us a grounding in what MPNs are, and I'm sure you'll enjoy his talk. Over to you, Martin.
Good morning, everybody. John, I'm not sure who you were referring to, this world-class person. My name is Martin Ellis, but everything else is not accurate, I'm afraid, except for the fact that I really do enjoy trying to understand more about MPNs and do treat people with MPNs, myeloproliferative neoplasms, and I also very much enjoy giving this talk, which is hopefully a useful introduction for this meeting, and I'd really like to thank the organizers at this point for inviting me again. John, Cheryl, Giora, I really appreciate it. I've been punished, more particularly you've been punished, because I have, I think, 4 presentations over the next 3 days. But I've not been punished at all. It's a great privilege and honor for me, and I really appreciate this opportunity. And I hope that we have some time to work through some issues regarding MPNs. It's an extremely exciting time to be working in this field now, as I'm sure you all know. Both the basic science and clinical science developments over the last few years are starting to bear real fruits in terms of medications that are available for our patients, and I'm sure we're going to talk about that quite a lot over the next couple of days. So this talk is supposed to be 1 hour long. The timer isn't working, which suits me absolutely fine, because I have been given a little leeway by the chairman, and I may go slightly over the time. The reason for that is because, as indicated, this is meant to be an introductory talk, but it's also meant to be a little bit beyond the basics. And what I've decided to do is to kind of split the talk into 2 parts. The first will be the longer part, which is really an overview of myeloproliferative neoplasms. And the second part is 1 or 2 issues that have come up over the last year or so that I find particularly intriguing and that I'd like to share with you. If I do find myself going over time, then I will just leave out 1 or 2 of the last parts of this talk. It's sort of modular, and if necessary, we can discuss those together during the weekend. Now, it tells me I have 39 minutes left to speak. I'm going to ignore the timer, and when somebody throws me off the podium, I'll stop talking. So the myeloproliferative neoplasms, there are a number of abbreviations that we'll get used to during this talk and over the weekend. Myeloproliferative neoplasm, MPN. From now, I'll just refer to them as the MPNs. We'll start with the basics and then move beyond. This is meant to make the slide go forward, but it's not doing that. Could I get some help, please? Okay, so the back button makes the slides go forward for the next speaker. This is my medical school in Tel Aviv, where I teach and work with medical students and residents and do some of the research that we're involved in with myeloproliferative neoplasms. And just to outline the talk, so we'll start at the very beginning about how blood cells are formed, where they're formed, We'll define myeloid disorders in general and talk a little bit about what we call the molecular pathogenesis, which basically means the molecules or the genes and their proteins that are responsible for the development and progression of these diseases. And then we'll go in a fairly systematic fashion through the three main diseases that we'll be talking about over this weekend, which are myeloproliferative neoplasms, polycythemia vera, or PV, essential thrombocytosis, or ET, and primary myelofibrosis, sometimes referred to as myelofibrosis, sometimes referred to as PMF, and sometimes referred to just as MF. So these are abbreviations that we'll use. For each one of these, we'll talk about the incidence, in other words, how often we expect them to occur in a population, what we see in the patients that we treat, the laboratory abnormalities that we may find, the treatment in very broad terms, and what the prognosis is for these patients. There'll be a tremendous amount of overlap, so there'll be repetition, which I think is perhaps useful, especially for people that are hearing some of this information for the first time or perhaps haven't delved into it for the past year. So I do not apologize for repetition. So things like the laboratory abnormalities will come up more than once during this talk, and if the first time you hear them it's too quick and perhaps you haven't managed to internalize exactly what I've said, not to worry, they will be mentioned again. And in fact, some of these issues like the gene abnormalities or the molecular pathogenesis, as I mentioned, will in fact be repeated in further talks throughout the weekend. In terms of beyond the basics, there are two particular issues that for me are very interesting at the moment. The one is what I've called here the MPN continuum. We tend to define the three main MPNs, which I'll show you in a moment, as separate diseases, different clinical entities, but you will also see that that's very confusing. It's confusing for doctors, it's confusing for me, and so I'm sure it's confusing for a lot of my patients and probably for some people in the audience as well. Are the MPNs really separate diseases? Are they one disease that can have different clinical manifestations at different time periods during a patient's journey through this disease? That is a question that's being answered, and we'll deal with that a little in the Beyond the Basics session. And finally, calreticulin, which is one of the molecular abnormalities, one of the gene abnormalities that we have in MPNs, has become very much center stage in the last year or two in terms of new information that we have about this particular gene. You're familiar, I'm sure, with the JAK2 gene, which was very popular over the last decade because that was the gene that we knew about in MPNs. Now I think it's calreticulin's turn, and I'd like to give you some of the updates that we've had this year in terms of calreticulin and the pathology that's related to abnormalities in calreticulin. I hope that we have time to cover all of this, as I said at the beginning. Where does it all begin? It begins in the bone marrow. So this is a cross-section of a bone in our body, one of the long bones in our body, let's say the femur in the leg. And if we cut this bone open, we can see that it's got different components. This is the hard part of the bone. When you have a fracture, this is the part that breaks, and that's very painful. The inner part of the bone is what's called spongy bone. Because it's not hard, it doesn't have calcium, which makes up the lining of the long bones in our body, but rather it has a large amount of fat in it. And surrounding the part of the bone that is surrounded by this fat is the bone marrow, which is where we make our blood cells. Now, this is very schematically shown over here, but it's just to show that really the bone marrow is in the center of our bones, typically the bones in the middle of our body, the breastbone, the ribs, our vertebra, and our pelvis. In children, bone marrow is active in the long bones as well, in other words, in the bones of our arms and our legs. As we grow older, and by the age of about 25, the bone marrow in the long bones of our body, arms and legs, is no longer active. And so really the active bone marrow that we have and the bone marrow that produces all our blood cells, this inner portion of the bone over here, is found really in the central bones in our body. And what happens over there? So the bone marrow is comprised of a number of cells called hematopoietic cells, which means cells that make blood, hematopoietic, making blood. And the grandmother or grandfather cell, grandparent cell, should we say, of the bone marrow is called a stem cell. I think you're familiar with the concept of a stem cell. Very difficult to define exactly what a stem cell is. We do not know what the precise defining element is, let's say a receptor or a protein on a cell that would say this is a stem cell and no other cell here is a stem cell. Scientists still have not gotten to that point. However, we do know certain things that define or characterize a stem cell. And here we are referring to the original cell that will make blood. So it's called a multipotent stem cell. By that I mean that it's a cell that has the potential to become any one of the three blood cells that we have circulating in our blood, the white blood cells, the red blood cells, or the platelets, as we'll see schematically further on. So this multipotent stem cell has a very special property. The first of the important properties is that it can replicate, it can make two daughter cells. We do use the feminine terminology when it comes to cell division. So the daughter cells over here are slightly more developed, they're slightly more mature. They've already decided fairly early on what cells they're going to be, a red cell or a white cell or a platelet. So we call these committed. In other words, they've committed themselves essentially to development along one of these particular lines, white, red, or platelet. However, the multipotent stem cell also has another property, and that is when it makes two daughter cells, one of the daughter cells will be a committed precursor cell, the other daughter cell will be an identical copy of itself. In other words, it has the property of renewing itself, so its two offspring are not identical, and that is a unique property of stem cells. Usually when cells divide in the body, a process called mitosis, division of cells, they will make two identical cells. When a stem cell divides, it makes two cells that are very, very subtly different one from another. One will be an identical copy, so we keep maintaining the stem cell pool so we can continue to make blood cells throughout our entire lives, from embryonic development all the way through adulthood. And the second cell will be a committed precursor cell that is already going to be going down one of the further lines of development. Now, as these committed precursor cells develop, they develop certain proteins that are associated with them, and typically we refer here to receptors or proteins that will be able to bind on the surface of the cell chemicals that float in our plasma. These chemicals are usually proteins, and when the proteins bind onto these receptors, which are other proteins, but these are on the cell, this stimulates what is called signal transduction, or very simply put, passing a message on into the cell. So the message comes in the form of a chemical, i.e. a protein, that is circulating in the liquid part of the blood, the plasma. That particular chemical, which is sometimes a hormone or a cytokine, another form of protein, will bind a very particular receptor on one of these cells. Here I'm showing you something called the Granular Site colony stimulating factor receptor. This was going to become a white cell. And colony stimulating factor will be a protein in the serum that will bind onto this receptor and cause something to happen in the cell. Usually it will cause the cell to proliferate. And when we have cells that proliferate, we have normal human development, but when we have cells that proliferate abnormally, we have cancer, in a sense. So this is a very early introduction for you into how cancer may develop in the body. In the normal course of things, if we have a cell that develops this receptor called the GCSF receptor, the granular site, colony stimulating factor receptor, granular site is another name for a white blood cell or a neutrophil. This will ultimately develop into a neutrophil. This is a picture of a neutrophil, or one of the types of white blood cells that we have circulating in our blood. This stage of development over here is going on in the bone marrow. When the cells are fully matured, they exit the bone marrow and enter the blood, where we can pick them up in routine blood tests. Here's another example of another receptor, the GM, or granular site macrophage. And this is going to turn into a macrophage, which is one of the other white blood cells that we have. Here is an example of another receptor, MPL. We're going to hear that abbreviation during the talk again. MPL is megakaryocyte or myeloproliferative leukemia receptor. This is going to become a megakaryocyte, which is a bone marrow cell that ultimately makes platelets that appear in the blood. And over here we have the erythropoietin receptor. Again, erythropoietin is a protein that circulates in the blood that is responsible for the promotion of the red blood cells to develop. And here we have the erythropoietin receptor. The EPO is the erythropoietin, the R is for receptor. That's on one of those early stem cells in the bone marrow. If the stem cell develops that receptor, then erythropoietin can bind to that receptor and cause red blood cells to develop as a result. So in the bottom part of the slide over here, we have the cells as they appear in the peripheral blood, that when we do a blood count, we can count, measure, look at under a microscope. And all of this up here is going on in the bone marrow itself. When we want to look at those cells, we have to do a bone marrow biopsy. So that's the basics as to where and how blood is formed. Now let's look at the myeloproliferative neoplasms, or the MPNs. As I said, there are three that we'll be discussing, PV, ET, and MF. And these are called the Philadelphia negative classic myeloproliferative neoplasms. This is a long name for these diseases. It's determined by the WHO that helps classify these diseases. And what exactly does this mean? This means that if we take one step back, we will see that there are other MPNs as well, which are not going to be the focus of this meeting this weekend. We've mentioned three of them. Here they are: ET, PV, and myelofibrosis. There's another called chronic myeloid leukemia, which is defined by a very specific gene and chromosomal abnormality and has essentially been removed from the discussion of myeloproliferative neoplasms. So we now refer to the Philadelphia negative myeloproliferative neoplasms, which means that there's a myeloproliferative neoplasm which is Philadelphia positive. Philadelphia is the name given to the abnormal chromosome that develops when two chromosomes translocate one onto each other because of a fracture of one of the chromosomes. That's the 922 translocation, called the Philadelphia chromosome. The chromosome 9 is called the Philadelphia chromosome, and that is what literally causes chronic myeloid leukemia. So if we remove the Philadelphia positive, we're left with Philadelphia negative, and that's what this part of the name comes to imply. The classic MPNs means that we're talking about these three diseases as opposed to other MPNs that are also Philadelphia negative that we do not discuss in this particular meeting. Those are diseases of the mast cells, mastocytosis, and of the eosinophils, eosinophilic syndromes. Mastocytosis and eosinophilia are also defined as MPNs by the WHO, but they are not the classic MPNs. So we have started with a big group of myeloid neoplasms, and we've whittled it down to the Philadelphia negative classic MPNs, of which there are three as they appear over here. Already on this slide, we can see that there are certain common features that exist between these three Philadelphia negative classic MPNs. And the most important common feature is this mutation that I think is probably familiar to most of you, the JAK2 mutation, which is fascinating and has really opened the door to a lot of the understanding of MPNs, and we'll talk about that at some length. So with that introduction, what really causes the MPNs? Well, the honest answer to that is that we do not know. We do not know why MPNs develop in almost all of our patients, but we do have some idea as to what is happening. So the question, especially when we ask by our patients, "Doc, why did this happen to me?" Usually the answer is, "I don't know." If the patient says, "What is happening to me?" then we can say, "Okay, you have developed a mutation, in all likelihood, in one of three very important genes that are responsible for the proliferation of blood cells as they develop in the bone marrow." And we'll look at these genes carefully one by one, but here they are. We mentioned already the JAK2 mutation. This is its number. It's called the V617F mutation. There is another JAK2 mutation, which we'll mention a little later on. The MPL mutation, if you remember, we saw that MPL is a receptor on cells that will become platelets, megakaryocytes. And the calreticulin gene, which is the third gene that is important in the development of MPNs. Now, these genes are so important that they've been assigned the appellation as being driver mutations. Driver as in vehicle. So these are mutations that will cause the disease to progress or to move along. Do these mutations actually cause the disease? No, they do not cause the disease. We still do not know what the underlying genomic or genetic abnormality is for MPNs, but it's safe to say that without the presence of these mutations, almost all MPNs will not develop and progress. We'll also meet a number of mutations during the weekend that are not causative mutations or not early occurring mutations or not driver mutations. So we call those mutations passenger mutations to keep the metaphor going. Those mutations are sometimes extremely important in determining prognosis for patients and determining whether the cells that are chugging along and replicating at a relatively constant and non-threatening rate will all of a sudden begin to replicate more quickly and develop into more aggressive myeloid malignancies, such as acute myeloid leukemia, or possibly myelofibrosis. And this will be a theme that recurs. So we have these three driver mutations, and then we have a very long list of passenger mutations about which I'll be speaking, I think, tomorrow, if I'm not mistaken. Now, this is how we imagine to ourselves it works. On the basis of a lot of scientific work that has been done, we can draw a cartoon that looks something like this. So this part of the picture over here is the cell membrane. This is what a cell membrane looks like in drawing. There's a bit of a lipid part of it and a bit of a tail to each of these molecules, and it's got a double layer. So this is how typically we represent any cell membrane in the human body. This is fairly constant. If we look over here, we can see a structure that looks like a line of sausages. This is meant to represent a receptor. This is a protein that is anchored into the membrane of the cell. Now, it's carefully drawn so that part of it extrudes and is outside the cell. This is the outside part of the cell, so this would be a cell that is washed with plasma. It's floating along in the bloodstream, and this part of the slide up here would be liquid, so it's plasma. That's the liquid part of the blood. This is the cell membrane, so this is the cell over here. So this is the inside part of the cell, and this is what's happening inside the cell. So this receptor starts off, part of it is outside, part of it goes through the membrane, and then it has a cytoplasmic tail, or part of the receptor being in the cytoplasm, which is the inner part of a cell. The cytoplasm meaning the liquid part of the cell, plasma usually meaning liquid. So this receptor lives quite happily until something links onto it. And over here we're seeing an example of erythropoietin, abbreviated as EPO, which is a protein. It's actually a hormone. It's produced in the kidney, and it's secreted from the kidney into the blood, into the plasma, the liquid part of the blood, and it circulates. And will have no activity at all in our body until, like a lock and key mechanism, it finds its lock. It is the key, and it finds its lock. And it will magically bind to part of this receptor because it has tiny little molecules on its protein structure that will recognize other molecules on the receptor. So it's a very, very specific binding. The hormone erythropoietin will not bind to thyroid tissue or to your eye or to your skin or anywhere else. It will only bind to cells in the bone marrow that have the erythropoietin receptor. So here's the erythropoietin, and here is the erythropoietin receptor. Okay, what happens once the binding has occurred? We have this thing called signal transduction, or in simple English, passing on a message. And the message is going to be cell in bone marrow, divide. Make another cell. That's how cells divide. They get an instruction from a chemical or a hormone outside of the cell. That instruction is passed on through binding to a receptor, and then this part of the receptor, the intracellular or inner part of the receptor over here, activates a whole lot of other messengers who are all proteins. All of these messengers are proteins, ultimately giving an instruction to the nucleus of the cell, which is really where all the action happens, to make more DNA and to divide. That's normal physiology. This side of the slide is normal physiology. And there are a number of names over here that are important in our field of MPNs. You'll hear perhaps about stats later on during the weekend. So JAK-STAT is a very important pathway over here. Now, I skipped over the JAK over here because JAK is really one of the main things that is involved in starting off this process of signal transduction. And these little P's over here stand for phosphorus. And what happens is that when the erythropoietin binds to its receptor, phosphorus is added on to JAK2. Once phosphorus is added onto JAK2, it causes the signal to be transmitted into the cell, from there into the nucleus, from there cells divide. A very basic look at the way cells divide, especially in the context of erythropoietin and red cell division in the bone marrow. Now, just to tell you what happens in MPNs, and particularly what happens in Polycythemia vera, and as I said, we'll repeat this a number of times. Well, what happens is we have this process occurring autonomously or automatically without the presence of erythropoietin. What we have over here is this mutation, the 617 mutation, V617F in mutation, causes phosphorylation of the JAK2 automatically and in an unwanted fashion. So we have the same outcome. We have over here the signal transduction occurring, but in a non-physiological way. There is no erythropoietin that has bound to the cell. So the body does not need to make more red cells to maintain its homeostasis or its normal balance of things. It is making more red cells because there is pathology, there is abnormality. And the abnormality over here is a very specific mutation in this gene that causes signal transduction to occur autonomously and unwantedly. The result of that is an excess production of red blood cells. As I said, we will repeat this. Now, that sounds like something that's causing a disease, and you might think, yes, well, that can cause Polycythemia vera. It sounds very logical, and indeed it is logical, but it's unfortunately not the entire story. Why? Because if we look at this JAK2 mutation over here occurring in a particular cell in our bone marrow, we know in certain patients and in certain experiments that there are mutations that occur even before that. Here's an example of one, a TET2 mutation in another gene. And without that TET2 mutation, the JAK2 mutation will have no effect. What I just told you would be a lie. So it's a driver mutation. It's important, but it is not the mutation causing the disease. On the other hand, we have the JAK2 mutation not only in Polycythemia vera with the erythropoietin story and excess production of red blood cells, but we have the identical mutation occurring in patients that have primary myelofibrosis or ET, which, as you'll see in a little while, clinically are different diseases. So we have patients who have the mutation, but if they only have that mutation and they lack other mutations, they will not develop disease. And we have patients that have that mutation but develop different diseases. So there is clearly more work to be done. And unfortunately, this is not a one-to-one equation, JAK2 mutation equals Polycythemia vera. It is much more complicated than that. But the JAK2 mutation is so important that it is certainly considered one of the driver mutations, if not the most important driver mutation. Just to summarize it in terms of numbers, so the JAK2 mutation is present in almost all patients with Polycythemia vera. About 95% of patients will have Polycythemia vera, with Polycythemia vera will have this JAK2 mutation. I'll skip down here and tell you that there is another mutation in JAK2. It's called the exon 12 mutation, and exon is part of the gene. And we simply call it the exon 2 mutation, and that occurs in 3% of Polycythemia vera patients. So it's still early, and arithmetic means that there are about 2% of polycythemia patients who do not have a JAK2 mutation at all. How do they develop polycythemia? We're not quite sure. On the other hand, the identical mutation in the lab, the scientists doing the molecular work will not be able to tell you that there's any difference between the mutation. The identical mutation will occur in about 50 to 60% of people with ET or PMF. So the identical mutation can give rise to 3 clinically different phenotypes or 3 clinically different pictures in our patients. And just to hark back to what I said before, this might actually mean that we're talking about one disease with different manifestations. But certainly in clinical medicine today, these are defined as different diseases, but they have the identical mutation. A little bit of a mystery to us as to how that can be. There are some answers being provided, which we'll deal with later on. So that was the first mutation, the JAK2 mutation, and how it works in terms of signal transduction. The other 2 driver mutations we'll deal with now. The first is the MAPL or the MPL driver mutation. This occurs in about 5 to 8% of patients with ET or MF. It does not occur in Polycythemia vera, and it occurs in a small number of patients with ET and PF and MF, as you can see over here. And ultimately, it results in the same thing. It results in that JAK2 overexpression and JAK2 overactivity, or JAK-STAT signaling, as I told you before. So we're getting the same result of all that message being sent down to the nucleus of the cell: divide, divide, divide. In an abnormal way, the body does not need to produce extra cells. There's no missing cells in the body for it to replace. But this is an autonomous process that's occurred. It occurs in a different manner. Here we have a mutation in the receptor for a hormone called thrombopoietin. So we said EPO is erythropoietin, TPO is thrombopoietin, thrombo meaning platelet. And we have the same kind of schema before. This is the cell membrane. This is this receptor. This is not the receptor for EPO. This is the receptor for TPO. Normally, TPO, thrombopoietin, would bind to this receptor and make megakaryocytes divide into platelets, same way that EPO makes red cells divide into other red cells. But over here we have a mutation, and here there are a couple of more mutations that can occur. It's not only one mutation, there's at least 3 or 4, where the result is that we don't need TPO anymore. This receptor is activated autonomously by the mutations that occur in its structure. So we can have the overproduction of megakaryocytes and the overproduction of platelets by having a MAPL or an MPL mutation that makes the physiology of having TPO bind when necessary completely redundant. It's a mirror of what we saw with the EPO and the EPO receptor. And then the third one was calreticulin, which is the relatively new boy on the block. And this was a mystery. No one knew that calreticulin had anything to do with bone marrow function. Cal over here stands for calcium, and reticulin stands for the endoplasmic reticulum, which is a small part inside the cell, which I'll show you in a little while. And this had something to do with protein development in general in cell physiology, and no one would have guessed that this had anything to do with hematology or with MPNs, but it turns out that it has. These mutations also cause cells to proliferate. So they cause the cells to undergo the same process as we saw with the JAK2 mutation and with the MAPL mutation. Until about a year ago, we didn't know why or how, and that's what I'd like to share with you a little later on. These mutations are found in the stem cells, in the very early cells that I showed you earlier on, so we can prove that this does have a relationship to MPNs. And it causes the same result that if you have a mutation in the calreticulin gene, you no longer need those hormones to bind their receptors to make cell division occur. So having a calreticulin mutation is enough to tell the nucleus to divide and divide and divide and cause an accumulation and a proliferation of cells that gives rise to the name MPN. The P in MPN is proliferation. So this calreticulin mutation was doing the same thing, in a sense, as the JAK2 mutation and the MAPL mutation was doing. How this was causing this to happen, as I said, remained a little bit of a mystery until recently. But again, it's fairly simple, because basically what's happening is we're getting activation of the JAK-STAT pathway. So all roads lead to activation of the JAK-STAT pathway, which is basically that signal or message pathway to the nucleus: divide and divide and divide. And we'll share with you later exactly what we think is happening there now, which is very interesting. Again, just to repeat and to summarize, we have three diseases: PV, ET, and primary MF. JAK2 mutation present in about 98% of people with PV. It's such an important mutation that, according to the WHO, you cannot have PV without having the JAK2 mutation. Essentially, in clinical practice, if we have a patient with polycythemia who lacks the JAK2 mutation, either the classic V617F or the rarer exon 12 mutation, we'll think 20 times before making a diagnosis of PV. Extremely rare. These other mutations, the MAPL and calreticulin, essentially do not occur in polycythemia vera. There have been isolated case reports of calreticulin in polycythemia vera, extremely rare. If we move on to ET, the split becomes much more even. So about 60% of patients with ET will have JAK2, about 30 to 40% will have calreticulin mutation, a small number, perhaps 5%, will have MAPL mutations. A very important piece of the pie over here is what are called triple negative patients. So over here we have yet another conundrum. We have patients with ET that have none of these driver mutations, and yet they still do have bona fide ET. In fact, these actually have a bad prognosis, these patients. So about 15% of patients with ET will not have any one of these three important mutations. And a similar picture emerges with myelofibrosis. The numbers are slightly different, and you can see the proportions are slightly different, but the picture is similar between ET and MF. There's a smaller fragment of patients over here that do not have one of the three driver mutations. And again, with MF, these patients have a worse prognosis, ironically, and exactly what the mutation is that's causing the disease in these patients, the triple negative patients, remains to be identified. I'd just like to take a step back and have, again, a look at the physiology of red cell production. And there's a specific reason for that, which you'll see in a moment. So this is a schematic view of it. This is the bone marrow. Those are the stem cells. These are the developing cells inside the bone marrow. They have slightly different names depending on which book you look at. And if you're looking at laboratory-based books or clinical-based books, these are basically red cells developing. When the red cells finally develop, ultimately into mature red blood cells, they leave the bone marrow and enter the peripheral blood, or the blood circulating in our body, the blood that we withdraw when we take a blood sample from our arm, and they form the red cell mass, the number of red cells that we have in our body. And those red cells are responsible in some way for the production of erythropoietin, which is the hormone. I said that it's a hormone that's produced in the kidney. That hormone is secreted from the kidney into the blood, and it will only be active on developing red cells in the bone marrow. So the way it would work is that if our red cell mass decreases, let's say because we have a chronic bleeding state, for example, so we're losing red cells because of a bleed through the intestinal tract or the urinary tract, whatever it may be, the kidney, through an oxygen sensory mechanism, will realize that there is a diminished number of red cells in the body, and it needs to make more red cells. So it will increase erythropoietin production, and erythropoietin will then stimulate the bone marrow to make more red cells to replenish that which has been lost, say, for example, through chronic bleeding. beautiful physiology. We call this a feedback loop. It occurs in a number of organs of the body, very common in the field of endocrinology, thyroid hormone, adrenal gland physiology, is all based on this concept of a feedback mechanism. That's absolutely normal. As mentioned before, this all breaks down when we have abnormalities of the JAK2 gene in the bone marrow, where this process occurs autonomously without any need for erythropoietin. So we've got this circle going on in a vicious manner with the overproduction of cells. But this is the physiology. And why do I show this to you here? Because you'll see a black box over here. What is going on over here? What is the oxygen sensation? And how is erythropoietin produced when we lose red cells? And I thought it would be neat just to show you that the Nobel Prize in Physiology or Medicine that was awarded, I think about a month ago, was awarded precisely for solving the puzzle of what's happening in that black box. These are the three gentlemen who won the prize, and they won it for their discoveries as to how cells sense and adapt to oxygen availability. It's an extremely important set of discoveries that was made about 15 years ago, and basically it relates to the oxygen tension or oxygen presence in cells, that when we have a normal amount of oxygen, what we have over here is two proteins that interact with each other, HIF1 and VHL. Now, these are very important proteins in polycythemia, in clinical polycythemia, but not in polycythemia vera. It's not something we talk about at this meeting often. Other causes of polycythemia, which are not polycythemia vera, which are very important in clinical medicine to diagnose, so as not to misdiagnose polycythemia vera. But these proteins are important in the physiology of erythropoietin. So if we have a normal amount of oxygen, these proteins, HIF1 alpha and VHL, are degraded and they don't act. However, in the context of a low oxygen content of the body, either because of lung disease, for example, or because of the loss of red blood cells because of chronic bleeding, these proteins remain active. They go into the nucleus, here's the nucleus, and they cause the stimulation of the production of erythropoietin. And you've seen how central erythropoietin is to red cell production until now. And I think that it's fitting that we just spend 1 or 2 minutes discussing this over here, since this is a very, very recent award that was given to these gentlemen for this extremely important discovery as to exactly how the normal physiology works. It breaks down in polycythemia vera, but again, it is important in other forms of polycythemia called secondary polycythemia or familial erythrocytosis, which are genetic abnormalities occurring in these genes over here, which are extremely important to diagnose so as not to misdiagnose people with polycythemia as having polycythemia vera. That was for the Nobel Prize. I'll skip this slide. So just to look at it again, as an introduction to polycythemia vera, which will be the first disease that we talk about, here we have the erythropoietin receptor. Here we have its connection to JAK2. You saw that in one of the previous slides. And as it is, nothing will happen. If we bind erythropoietin, we will then get a change in the conformation of this receptor. We will get phosphorylation of the JAK2, and we will get production of red blood cells through the signal transduction mechanism involving STAT and other proteins as well. That's normal physiology. For that, you can get the Nobel Prize. In polycythemia vera, we have this happening automatically or autonomously. There is phosphorylation of JAK2 because of that mutation. There is signal transduction that occurs even when we don't want it to happen, and that results in more and more red cells being produced. With that, let's have a fairly didactic look at polycythemia vera. So, this is a universal or a global disease rather, slightly less common in Japan. Patients are typically in their 60s when they're diagnosed. However, you will see a significant number are much younger, and about 10% of patients with polycythemia will be diagnosed below the age of 40 years, which is extremely significant. These people are expected to deal with this disease for a long time. It's more common in men, and it's approximately occurring in about 2 per 100,000 individuals in most societies. My personal feeling is that it's more common than that, perhaps 5 to 10 per 100,000, but the official number is 2 per 100,000, which makes this a very rare disease compared to other human diseases. There is a certain familial tendency, so this is not to say this is a hereditary disease. You cannot tell someone with polycythemia vera that their offspring has a 10% or 20% or 25 or 50% chance of developing this disease, but we see lots and lots of patients who have a family history of polycythemia vera, or to be more fair, not only polycythemia, but one of the other MPNs occurring in their family in a first or second degree relative. That is not an uncommon occurrence. in the vast majority of patients, we will not be able to tell them why this has happened. We're quite good at telling them what has happened, but not why. The NCCN is an American association or organization called the National Comprehensive Cancer Network, which is very important because it does a lot of tremendous work. One of our previous speakers over here, Professor Ruben Messer, is very involved in defining the guidelines from this organization, which are critical in the United States because they actually serve for funding purposes, the basis for deciding on what should be funded. And here's from one of their updates that they gave recently for the MPNs, the diagnostic criteria for polycythemia vera, which they took from the WHO. These are the most, again, globally accepted definitions for the MPNs, those that are defined by the WHO. And here they are. They're quite complicated, but let's just go through them quickly. There are major criteria and minor criteria. The major criteria is that you have polycythemia, that you have an elevated level of hemoglobin or an elevated hematocrit, which is the other laboratory measure for hemoglobin in the body. And these are the numbers. They're slightly different for men and for women. And this is a big deal because the previous version of the WHO criteria, which were published in 2008, had higher numbers. The hematocrit and hemoglobin were higher. In 2016, they reduced these numbers in order to catch patients that have very early forms of polycythemia vera who also need medical attention because they have a bad prognosis. And we'll talk about that. It's now called early polycythemia vera. So these are the new numbers that we follow. These are very readily available on any blood count throughout the world. You will get the hemoglobin level and the hematocrit on your blood count result. There's another way of diagnosing polycythemia vera, and that is looking at the red cell mass. If you remember, that was a term that appeared in one of my previous slides. This is a much more complex diagnostic test, which is almost not done anywhere in the world today because it involves the use of radioactive isotopes, which nobody really wants to work with. But it is probably the most direct and accurate way of diagnosing polycythemia. If we have time in discussion, we can talk about that. But it's not a practical test that is used today. The bone marrow biopsy is important, and we'll talk about that. There are specific features in the bone marrow when we do a biopsy of the bone marrow that will indicate polycythemia vera, as opposed to other causes of polycythemia, like familial polycythemia, or as opposed to other MPNs, like ET or MF. As I intimated at the beginning, sometimes it's quite difficult to tell one from another in terms of MPNs. Finally, the third major criteria is, in fact, the JAK2 mutation. You need to have the JAK2 mutation to make this diagnosis. WHO says if you have all three major criteria, hemoglobin, bone marrow, and JAK2, you have polycythemia vera. However, they do acknowledge the fact that you can have the first two major criteria, i.e. the hemoglobin and the bone marrow. You do not have the JAK2 mutation. Remember, we said there are about 2% of people with PV who will not have the JAK2 mutation, but then you have to have a low level of EPO. And the low level of EPO comes because of that recycling phenomenon or that feedback loop that I showed you, that if autonomous red cell production is occurring without the necessity for erythropoietin, the levels of erythropoietin in the body will decrease. So that's a finding over here that's called a minor criteria. What do the patients look like? What do they sound like? Sometimes they can be asymptomatic, in other words, have no symptoms at all, but very often they'll have symptoms which relate to their head. So they'll have headache, they'll have visual disturbances, sometimes they may have hearing disturbances, they may have tinnitus, which is a ringing sensation in the ears. They very often have fatigue for reasons that are not entirely understood, but fatigue is very important. Itch, which is called pruritus, and this itch often occurs after exposure to water, and sometimes to warm water, so it's called aquagenic pruritus. It can be so extreme that some patients will tell you that they actually desist from bathing for days on end because after they take a shower or a bath, they are in such discomfort that they cannot bear to do that. When you examine them, they have this appearance of plethora, which is basically ruddiness, a red appearance, and the other thing of the skin. And the other thing that you notice on physical examination often can be an enlargement of the spleen, which is a common feature to myeloproliferative neoplasms. And here's a picture of plethora. Laboratory abnormalities, as we've mentioned, by definition, there will be an elevated hemoglobin or hematocrit. Not in all patients. Patients with early polycythemia may trick us, or patients with polycythemia who have blood loss for a certain reason. For example, a cancer of their colon that is bleeding can auto-correct their hemoglobin, which they're overproducing in their bone marrow, by losing it through their intestinal tract, for example. So sometimes this criteria can be problematical. An elevated red cell mass, as I said, that's a radionucleotide scan, which is not really done. Often, patients will have high white counts, leukocytosis, and high platelet counts on their blood counts, thrombocytosis, indicating to us again that this JAK2 mutation is occurring in the stem cell, that very, very early cell that hasn't quite yet decided whether it will be a red cell, a white cell, or a platelet. And this again brings us to this concept of the continuum between the different MPNs, the ET, the PV, and the MF, which we'll discuss later on. The blood chemistry tests which we perform in these patients show abnormalities. Often uric acid is a component of cells which increases when there is a rapid cell turnover. And LDH, which is an abbreviation for lactate dehydrogenase. It's an enzyme that is found in developing cells in the bone marrow, and when there's proliferation of cells in the bone marrow, the LDH value is often elevated. That's a non-specific test. The LDH can be elevated in a number of other clinical entities. Blood tests, again, serum erythropoietin may be low. It's one of the minor criteria, and we can now, since it's been discovered, we can look for the JAK2 mutation in peripheral blood. So all of these are simple blood tests that can be done very often in a primary physician's office if he's aware of the potential for this diagnosis and knows which tests to send off. But certainly in a hematologist's clinic or office, these are very simple tests that are done simply with a needle stick of the arm. No need for bone marrow biopsy at this point. However, in order to conform with the WHO diagnostic criteria, we do need to do that bone marrow biopsy, and this is what we'll find. This is a normal slide of a bone marrow. These white globules over here are fat, which, as if you remember from one of the original pictures, there is fat around the bone marrow, so we expect to find fat in a bone marrow. And here you can see a bone marrow that has absolutely no fat in it at all. It's almost 100% cells, where here you'd have about 60% cells. The term that's used for the findings on the bone marrow in Polycythemia vera is trilineage hyperplasia. Trilineage means the three lines. In other words, the white cell line, the red cell line, and the platelet line. And in the bone marrow, the platelet line are megakaryocytes, which are these bigger cells that you can see protruding over here. All three of those are increased in number in the bone marrow in Polycythemia vera, which again raises the question why. If this is a disease which is going to cause red cell production, why is the bone marrow overproducing white cells and platelets in the bone marrow in terms of megakaryocytes as well? One of our issues that we have to deal with. We're now starting to look at the genetics of Polycythemia vera on a routine basis, and we look at their chromosomes, and we are now getting to know that there are certain chromosomal abnormalities that tend to recur in patients with Polycythemia vera, and these are starting to be used in prognostic scoring systems, some of which I'll show you a little later. So we might be entering a new era where we can differentiate between PV patients at a lower risk or a higher risk, depending on whether they have chromosomal abnormalities as well. I would not consider this to be routine testing at this point, so chromosomal abnormalities are not yet considered a routine part of the workup for patients with Polycythemia vera. Just a schematic as to how we make the diagnosis, things that we've already said. So we start off with peripheral blood, simple blood test for two things. Looking for the JAK2 mutation, which is done using a test called polymerase chain reaction, PCR, which is a very commonly used test in laboratories all over the world, and a chemistry test looking at the level of the hormone, the serum erythropoietin. If we have the mutation and erythropoietin is low, if you remember the WHO criteria, we're nearly there. Clearly, we're starting off with a patient who has a high hemoglobin or a high hematocrit. So it's very likely this patient has Polycythemia vera. It's encouraged to do a bone marrow biopsy so that we can be good about fulfilling the WHO criteria. It's not entirely essential, and I think it depends on where you're practicing and how easily you can get a bone marrow biopsy done. But certainly today, we try and do bone marrow biopsies in all of these patients because we don't know what the future holds. We don't know whether this patient is going to be on a continuum, and in a couple of years' time, he'll have fibrosis, and we'll want to know, was the fibrosis there at the beginning or not? Has this patient transformed? It's something we'll be talking about this afternoon or not. So a bone marrow biopsy is important, but to be fair, it's often skipped if we have enough of these criteria, but it really shouldn't be because it's an essential WHO criteria. On the other side over here, if we do not have the V617F mutation or the exon 12 mutation for those other 3% of patients, and the erythropoietin level is normal or high, it's very unlikely that these patients have P. vera, and we should be thinking about other things like congenital polycythemia, apropos the Nobel Prize that we spoke about earlier. There'll always be patients in between who have one abnormal test, but the other test is normal, so we often repeat the tests, and these are patients in whom bone marrow biopsy can be very important and very informative in terms of making the diagnosis. The treatment. Very briefly, the treatment is control the hematocrit. In polycythemia vera world round, we talk about hematocrit. In the United States, they only talk about hematocrit and don't use the hemoglobin as a reference point. In most of the world, the hemoglobin is the standard reference point for red blood cells, but in polycythemia vera, everybody talks about hematocrit. We want that hematocrit at less than 45%, and the variety of ways of doing that by drawing blood, phlebotomy, which is really the same as blood donation, basically, in terms of the way that it's done. In patients over the age of 60, we'll prefer to give one of these drugs, hydroxyurea. There are other drugs that are available, but hydroxyurea is the standard drug. And the reason for that is because this has a greater efficacy in terms of preventing what we'd like to prevent in polycythemia vera, which is complications related to blood clotting, which we'll talk about. Interferon is a drug that's becoming more and more important. It's used now exclusively in pregnancy, but it looks like it's going to become a drug that's going to be useful in other forms of polycythemia vera or later stages of polycythemia vera, as is ruxolitinib, which is licensed and used in patients that have resistance to hydroxyurea. So that's the first element of treatment, a very important element, control that hematocrit, and we'll speak about why in a moment. The second important element is to give a drug that prevents platelets from clumping together. Platelets are those blood cells that are important in stopping bleeding when we have bleeding. Those are the cells that are typically causative of diseases like stroke or transient ischemic attack and myocardial infarction, heart attack. And that occurs because platelets tend to clump around plaques that form on the inside parts of our arteries, atherosclerotic plaques, and cause those diseases, stroke and heart attack, in the general population. In patients with PV, one of the main risks that they have is the development of abnormal clotting, so heart attack and stroke on the one hand, that's in the arteries, and deep vein thrombosis or pulmonary embolus, which are clots that form in the veins and can fly off from the vein into the lung, that's the pulmonary embolus. And it's been proven in clinical studies that one of the ways of preventing that is to give aspirin to prevent that platelet activity and the platelet clumping. So that's the second very important element of treatment over here. Controlling the hematocrit and giving an antiplatelet drug will decrease the risk of a patient developing one of those clotting abnormalities. So just to have a look now, an overview of polycythemia vera. Patients start at an early phase. And this includes what we now call early polycythemia vera, or not what we once called masked polycythemia vera, which is sort of a bit of a term that's under some debate whether it should be called masked polycythemia vera or not. But basically what it's coming to tell us is that there are patients with polycythemia vera who at first may have a normal hematocrit. And this sounds counterintuitive because it's polycythemia. They have a lot of red blood cells. How come they can have a normal hematocrit? There are a variety of reasons for that, but this is an important group of patients to diagnose. Very often, as we'll see in one of the slides later, they can be diagnosed with a high platelet count, and you may think at first that they have essential thrombocytosis, but it'll turn out over time that they have polycythemia vera, and I'll show you that. Then we come to the stage of the disease, which is the polycythemic stage, which is easier to diagnose because patients will have a high hematocrit, a high hemoglobin. And this can go on for a number of years. And then they develop the last stage of their disease, which can either be myelofibrosis, secondary to polycythemia vera, something we'll talk about this afternoon, or a small fraction of patients can develop acute myeloid leukemia, from which they will probably not recover unless they're fortunate enough to get chemotherapy and have a bone marrow transplant and have all of that work. So how does it look in terms of numbers? About 5% of patients will develop leukemia at some point of their disease, usually after a number of decades. A higher fraction of patients will develop post-polycythemia myelofibrosis, about 15%. As I indicated, the main clinical problem, and the problem that we focus on in daily clinical practice, is thrombosis and preventing thrombosis. As mentioned, heart attack, stroke, thrombosis in veins. Sometimes the veins are unusual veins, like veins in the abdomen, veins of the liver and spleen, portal vein thrombosis, veins in the brain. cerebral vein thrombosis. Those are all complications that can occur from polycythemia vera. However, effective treatment really reduces this number to single digits, and perhaps even to 4 or 5%. There's still a fraction of patients with the best of treatment that will have a thrombosis, but without good treatment, this number is exceedingly high, up to 40%. And ironically and paradoxically, a small fraction of patients without treatment may even develop some bleeding complications for reasons that we can go into in discussion later on. Moving on to ET. Again, all populations, slightly lower age of onset, 55, and here we have more women than men. The incidence is fairly similar, 2 to 3, perhaps up to 5 per 100,000 individuals in the population. The same schema we have, the WHO, as brought to us by the NCCN. Again, major criteria, minor criteria. Here we need the high platelet count. Here the bone marrow is very important because bone marrow findings are subtle but important. And we need to have one of these mutations. If you remember, we had the 3 driver mutations in varying proportions in our patients, so we check for all of these mutations. There are other markers, the so-called passenger mutations that we'll mention later on this afternoon, that can be present in these patients and can be useful for making a diagnosis as well. This is just a blood smear of what it might look like. These are platelets, these tiny little cells. These are the red cells in the background, and these are white cells, the big cells. Here's the number of platelets you may expect to see in a patient with ET, obviously majorly increased. Here's the bone marrow biopsy. These are the numerous megakaryocytes, these big cells. The background cells here might be white cells or red cells, but these giant cells, the mega in megakaryocyte, quite clearly. And here's one which you can see is really a giant cell and very abnormal. How do these patients present to us? What we call microcirculatory abnormalities are very common in these patients. The microcirculation are the tiny blood vessels, usually in the distal or the end parts of our body, the end parts of our fingers and toes, which can sometimes be extremely painful and red. It's called erythromelalgia, headache, abnormal neurological sensations, usually in the fingers and toes, again called paresthesia, visual abnormalities, black spots that can appear in a visual field, blurred vision. All of this can have to do with blood flow in the retina, hearing loss, and the tinnitus, the ringing sensation in the ears, and TIA, transient ischemic attack, which is a minor stroke. People may lose sensation in a part of their body or lose function in a part of their body temporarily, usually for minutes or hours, only to have it come back as those platelet clumps that develop disperse themselves and allow blood flow to renew to the brain in a normal way. These patients can also have thrombosis or blood clots in major vessels, so in a blood vessel in the leg or the lung, or a heart attack because of an occlusion of a large blood vessel around the heart, or a stroke, a large blood vessel in the vein. Again, paradoxical bleeding occurs in these patients, typically when the platelet count is extremely high. I went over it quickly, but the normal platelet count is up to about 450,000 platelets per microliter of blood. If you get up to values of 1.5 million platelets per microliter of blood, those platelets not only cause clotting abnormalities, but they stop functioning as normal platelets, and they can cause bleeding abnormalities as well in a paradoxical way. This is just what thrombosis looks like. This is a peripheral vein under the skin that has a blood clot. You can see it over here. This is a deep vein thrombosis of the leg, which will cause swelling of the entire leg with redness of the leg. I will show some clinical pictures throughout my talks. All of these pictures are shown with permission of the patients, and none of them have identifying features, as you'll notice. This is the microcirculatory or the peripheral thrombosis that you can see, the purplish discoloration over here on the tips of the toes of this gentleman who had 2 million platelets circulating in his blood and needed urgent treatment. Hemorrhages, these are sort of what might be called blood blisters under the lip, rather larger bleeding under the skin, and then smaller bleedings over here seen at the tips of the patient's fingers. Laboratory, by definition, will have a high platelet count. We might also have a high white count, bringing us back to the story that these abnormalities in the genes are stem cell abnormalities, so very often the white count will be elevated as well. By definition, we'll have a normal hemoglobin. If the hemoglobin is elevated, we'll be diagnosing polycythemia vera and not essential thrombocytosis. That uric acid can be elevated as well, and we will find in about 85% of patients one of these 3 driver mutations in the varying proportions that I showed you earlier on in the talk. How do we treat these patients? Again, the aim of treatment is really to prevent clotting, to some extent to prevent bleeding, but that's a more minor problem, but it's mainly to prevent clotting. And we look at our patients and we divide them into two groups. Those are at, well, now it's more than two groups, it's about 4 groups as you'll see, but into groups of patients depending on whether they have a high risk for clotting or not. Typically, patients who are at high risk for clotting will be older than 60 years of age, or they've had a history of thrombosis. They've had a previous thrombosis. Either one of those two, we know from clinical studies that have been done, puts patients at a very high risk for repeat thrombosis. But it's a little more complicated than that now. What was a binary or a 2-group definition, high risk and low risk, is now 4 risk groups. We have patients that have the JAK2 mutation, patients that do not have the JAK2 mutation and do not have cardiovascular risk factors like smoking, hypertension, diabetes, high cholesterol levels. We have patients who do not have the JAK2 mutation and do not have any cardiovascular risk factors. And then we have the high-risk patients. So if you have the JAK2 mutation and you're at low risk, i.e. you're less than 60 years old and you've never had a blood clot before, you will still be given aspirin. And that reflects the fact that this JAK2 mutation, in addition to being a proliferative mutation, as I showed you earlier on, is also a thrombogenic mutation. In other words, it causes the cells to overreact, particularly platelets, and to be platelets that are more likely to be more sticky and more likely to make a blood clot than platelets in patients who do not have the JAK2 mutation. So all patients with a JAK2 mutation in ET will get aspirin. If you do not have the JAK2 mutation, remember that's about 40% of patients, perhaps 45% of patients who do not have the JAK2 mutation, and you're otherwise healthy and young and have never had a blood clot, that's why you're low risk, you'll still get aspirin. So that's if you do have the cardiovascular risk factors. So if you're 50 years old and you're a smoker and you have ET with no JAK2 mutation, you have a cardiovascular risk factor, you'll get aspirin. However, if you're 50 and you do not have a JAK2 mutation and you're a marathon runner, you'll have absolutely nothing. You'll just be observed. If you're a high-risk patient over the age of 60 or you've had a previous clot, you'll get the whole lot. That means you'll get aspirin and you'll get a drug to reduce the number of cells, which simply is called cytoreductive therapy. And cytoreductive therapy can be along the lines of any one of a number of drugs. The typical drug that is used is hydroxyurea. Some patients will get interferon as well. A drug that's fallen out of favor to some extent is anagrelide, and then busulfan in patients that are older. Topics for further discussion as necessary. What happens to these patients? Well, as opposed to polycythemia vera, I think overall these patients live the same duration that patients in the people in general population will live. So depending on at what age they're diagnosed, you can tell them more or less what their prognosis is. There are some groups that will differ with this conclusion and say that even these patients have a slightly shorter lifespan than the general population, but I think that's a little bit debatable. Thrombosis is the commonest problem. A lower rate of thrombosis than we had in polycythemia. If you remember, that was 40%. This is less than that. And here, arterial thrombosis, meaning heart attack and stroke, is more important than the venous, so deep vein thrombosis and pulmonary embolus. Bleeding, paradoxically, in a small number of patients. Here, the myelofibrosis rate is lower. It's 1% at 10 years and about 10% at 15 years, and a much lower proportion of patients develop leukemia than in polycythemia vera. So overall, we're getting a picture that polycythemia vera is a slightly more, or not slightly, but a more aggressive disease than essential thrombocytosis. Primary myelofibrosis, this is just to show you what the bone marrow in primary myelofibrosis may look like, with these black strands being reticulin, which is a precursor form of collagen, which is the fibrosis or the scar tissue that occurs in the bone marrow. Now, this is really, I think, the bad actor in the MPNs. What happens in these patients is that the bone marrow may fail, so the patients may develop low blood counts, all blood counts being low. The white count may drop, the hemoglobin may drop, and the platelet count may drop. And if all of those three drop together, that is called pancytopenia, low counts all around, the pancytopenia. These patients are very, very symptomatic. They have a lot of symptoms. The symptoms may be generalized, or what we call constitutional symptoms. We'll discuss those in detail. Or related to the spleen, which is typically enlarged in these patients, and we'll deal with that as well. When we examine them, they typically have splenomegaly, and sometimes these patients may have an unfortunate condition which is called extramedullary hematopoiesis, which means that other tissues in their body, outside of the bone marrow, the medulla is the bone marrow, so tissues outside of the bone marrow start making blood. In other words, we have tumors or tumor-appearing structures outside of the bone marrow that are making blood, and I'll show you some pictures of those. all populations around the globe, slightly older population over here compared to PV or ET. We do not know what causes this, and again, we have this magic number of somewhere between 1 and 5 per 100,000 individuals. The NCCN once more brings us the 2016 WHO criteria, very complicated. I show this for one simple reason, and that is to show you that we are now recognizing an early form of PMF, of primary myelofibrosis. And this is given the difficult and unfortunate name of pre-fibrotic myelofibrosis. Again, there are some paradoxes in some of these names. It's like early polycythemia vera, so you can have polycythemia vera without polycythemia. You can have myelofibrosis without having myelofibrosis. I think these really come to teach us that these diseases develop, and they develop over time. It's not like yesterday you didn't have MF and today you have it. Yesterday you didn't have PV and today you have it. There is a time period, there's a lag, there's going to be a period there where you have difficulty finding all of the criteria to make these diagnoses. A lot of the words over here are just describing what's present in the bone marrow, but there's a long list of minor criteria over here which basically relates to other blood count abnormalities, the LDH, and particular features on a blood smear, which I'll show you as well. So the clinical features that these patients may have. And here we can divide them into two. Firstly, there may be clinical features that relate to a chronic inflammatory state which is mediated or caused by these cytokines. If you remember, I mentioned these as certain proteins that might be circulating in the blood, and he has a long list of proteins. All of these are the kind of proteins that increase in our body when we have the flu. So if you think of the worst viral infection or pneumonia or bronchitis that you've ever had and how you felt in terms of your muscles and your aches and your headache and your fatigue, if you can just imagine that for a second, that's myelofibrosis. And that's how people have to live when they have myelofibrosis. And then you have the proliferation over here, which really gives rise to the spleen, which can become very large and painful. The symptoms of itch and weight loss are very prominent in these patients as well. So it's a sort of a combination of what we call constitutional symptoms, which may be low-grade fevers, sweating, loss of weight, itch, very, very severe lassitude and fatigue on the one hand, and then an enlarging spleen which can cause abdominal pain, difficulty in eating, nausea, and localized symptoms to the abdomen where the spleen is found. These would be the kind of symptoms that we find in patients with myelofibrosis. We need to add to that the hematological abnormalities, and one of the main symptom-generating features of myelofibrosis is anemia. We said that the bone marrow fails at this point, and anemia really causes, again, fatigue, difficulty to function, dizziness, shortness of breath. So there's a gamut of symptoms which are really, really important and may range from mild to very severe in patients with polycythemia vera. These are just pictures of a patient of mine with extramedullary hematopoiesis. So these are all tumors that are developing on this patient's body, on his chest, and on his head. This is, again, an unusual feature of myelofibrosis. How do we see these patients in the lab? Blood count abnormalities are variable. So we said that there's pancytopenia, reduction of blood counts, but very often these patients along the way will have increased blood counts, increased white cells, and increased platelet counts. They have an elevated LDH, that's the lactate dehydrogenase, and the uric acid because of rapid cell turnover. And here, the chromosomes and the gene mutations are very important in defining the prognosis. So if I said that chromosomes are only starting to make it into PV, they haven't yet made it into ET at all. In myelofibrosis, they are central, as we'll see in a while. Just to show you this, we saw this before, the gene mutations which are so important, the JAK2 mutation in slightly more than 50% of people, about 30 to 35 with calreticulin, about 5% of the MAPL, and then about 15% or perhaps 10% without any of these mutations, the so-called triple negative patients. We make the diagnosis because we see a typical blood picture, which I'll show you. The patient has splenomegaly. Often we'll try and aspirate or suck with a syringe bone marrow out of the bone marrow cavity, and we won't be able to because the bone marrow is completely fibrosed, it's completely scarred. However, when we do the biopsy part of that test, we will see the fibrosis. So the aspiration, which is to get the liquid marrow out, will fail. The biopsy will succeed. It doesn't always fail, but it may. We don't have any other cause for this patient's disease. That's part of the NCCN and WHO criteria. And most of these patients will have some molecular abnormality, as we saw, one of the 3 driver mutations or other passenger mutations. Blood cells look completely abnormal on a blood smear. These are normal-looking red blood cells. These are blood cells that have gone through a fibrotic sieve, if you will, in the bone marrow and get deformed. They're called teardrop cells. And here are better examples of teardrop cells. These are abnormal, and this is a young red blood cell still with its nucleus, which should not be in the peripheral blood. This is a peripheral blood smear. This should only be found in the bone marrow, and here it's made its way into the peripheral blood because the bone marrow is fibrosed and abnormal and doesn't block the exit of those cells from the bone marrow into the blood. The bone marrow abnormalities are shown over here. I won't dwell on them. How do we know which patients with myelofibrosis are going to do worse and who are going to do better? There are a number of risk stratification models which take into account a number of very simply attained variables, so the patient's age, whether they have symptoms or not, a high white blood count, a low hemoglobin, blast cells, which are early white blood cells in the peripheral blood, a low platelet count, do they need blood transfusions, and do they have abnormal chromosomes. The initial system that we used was called the International Prognostic Scoring System. That was modified to be a dynamic system, and then it was Dynamic System Plus, which includes these three features which were not in the original scoring systems. And the more ticks you have against your name, the worse your prognosis is. And this is what it looks like if we look at these curves, which are called Kaplan-Meier curves, named after two statisticians who worked out this form of following patients. Excuse me. These are patients who will have low risk, so they have very few ticks next to their names. They may be younger, they don't have constitutional symptoms, they don't have peripheral blasts, they have a better hemoglobin, a better platelet count. They all have myelofibrosis. That's what you need to get into this, of course. And they will live for a long time, 17.5 years and more. However, if you've accumulated a lot of ticks next to your name, the median survival here is less than 2 years. Clearly, these patients need less of our attention, and we need to be a little less drastic when we come to think about treating them. But these patients on the very low curve, and perhaps the curve above that, who will only live for about 4 years, need our attention, and we need to do something drastic in order to try and cure these patients and prevent them from falling onto these curves over here. We now have the luxury of knowing what happens to our patients who have these various molecular abnormalities, the driver abnormalities that we've spoken about. And here we have the 4 different options. So you can have the Calreticulin mutation, the JAK2 mutation, the MAPL mutation, or none of these mutations. We see over here that the Calreticulin mutation has the best prognosis, and having none of the mutations, ironically, has the worst prognosis. So this molecular risk stratification is going to be added on to the other stratifications that I've shown you, and I think we'll be talking about that tomorrow, if I'm not mistaken. But just to give you a quick intro on one slide, these are the latest, in fact, there's one that's even more current than this, the latest risk stratification systems that are developed, and they're now getting very, very complicated, where we need to know the specific type of Calreticulin mutation we have, the carrier type, these high molecular risk passenger mutations, and it's becoming more sophisticated. The MIPS 70 plus, which is the newest Italian version over here, in fact, does not have any clinical it has one clinical abnormality included in it, but it really relies extensively on these new mutations that we'll be speaking about later on in the meeting to give us these same types of curves, but you can see how the curves become more separated one from another, and we can really define who are the patients with an excellent prognosis and who are the patients with a very, very poor prognosis using more and more information, which is becoming actually more molecular and a little less clinical, as we'll see. And what do we do with that information? So we have a patient who has a low risk or an intermediate risk or a high risk. It helps us frame our treatment approach to these patients. Clearly, patients at the highest risk who are going to live 1 or 2 or 3 years, we have to be drastic, and really we want to just try and get them a new bone marrow, if possible, and we'll do an allogeneic hematopoietic stem cell transplant if we at all can. If we can't, we'll really try something investigational. Perhaps we've got a new drug that can help these patients. On the other side over here, if we've got patients who are really at low risk, who we expect are going to live for 20 plus years, and they're not symptomatic, which is possible, we'll do nothing at all, which is sometimes a little counterintuitive for doctors and for patients. Well, why shouldn't we give these patients ruxolitinib? We don't give them ruxolitinib because ruxolitinib doesn't change the history of the disease, and it doesn't treat symptoms that don't exist. On the other hand, if we have patients at a low or intermediate risk who are symptomatic, then we can start talking about giving treatment for symptoms, and we'll talk about that in a moment. And here it is. So how do we treat the symptoms related to PMF? So again, 3 groups or pods of symptoms. The constitutional symptoms, That's where ruxolitinib really has made a huge difference to patients. Ruxolitinib is a fantastic anti-inflammatory drug, and when it works wonders for these patients. Patients gain weight, they stop having fevers, they lose this terrible feeling of having the flu on a chronic basis, basically. Fedratinib, you'll be aware, was approved about 2 months ago, if I'm not mistaken. Exactly how this is going to fit in. Right now, it's used for patients who've failed ruxolitinib. Is it going to become first-line treatment? Steroids are commonly used as well for treating these constitutional symptoms. The spleen is also well treated by ruxolitinib. It's also well treated by fedratinib. And sometimes we need to be a bit more drastic with this treatment of the spleen, including removing the spleen or irradiating the spleen, although those procedures now are done less and less, that we have drugs that can try and help us. And these very invasive procedures relating to the spleen are not usually very successful. Anemia, well, we use erythropoietin, that hormone that I mentioned earlier, but in supraphysiological, in other words, in pharmacological concentrations, very high concentrations, androgens, which are male hormones, thalidomide, blood transfusion, and right now we're starting to see the entry into this field on an investigational basis of new drugs, including one of the drugs that was developed on the basis of the information generated by the Nobel Prize winners, a drug called roxadustat, which is an HIF-1 alpha inhibitor, which increases the HIF-1 levels, and so we'll be seeing that in clinical trials in myelofibrosis soon as well. We're going to wrap up now. Okay. So I think what I've tried to do is show you in very broad terms that there's a continuum between all of these diseases, and I'd just like to finish now by showing you one or two things relating to this, which I think may be useful. If we look at this very schematically, if we look at the red cell count, the platelet count, splenomegaly, and fibrosis, and our 3 Philadelphia negative classic MPNs, all of the patients with PV will have erythrocytosis, and none of these will. However, if we look at platelet count, well, some of these patients with PV will have a high platelet count, all of the patients with ET will have, and PMF, some will. The same goes for splenomegaly, the same goes for fibrosis, and the same goes for the complications. So there's a tremendous overlap when viewed like that. And when viewed like this, you can see again these Venn diagrams intersect all over the place. So patients sitting over here, it's very often confusing for everybody to try and understand exactly what their disease is and what's going to happen. And what may be causing this variation in the clinical presentation. Clearly, it seems to be the number of mutations that patients have. Those passenger mutations are very important. We now know that there are inhibitory mutations. There are mutations that can inhibit JAK2 mutation activity. And we also know that a very important concept called the allele burden. In other words, how many of the cells in the bone marrow actually have the JAK2 mutation, and that can change over time, something called the allele burden. And that's a known fact for JAK2, and it might be correct for other things as well, such as the MAPL and the calreticulin. So all of these things now are interacting and giving us some insight into why patients can change and can be at different points of the continuum along the way. And this is a brand new article from just a couple of months ago from one of the important investigators in this area. I'm not going to go into this side of the slide, which takes us back to the stem cells, and that one simple stem cell is not really a simple stem cell. There are various levels of stem cells, and where exactly the mutation is occurring may be very important. But just to look at a slide over here, and show you that this is a hemoglobin level. This is a patient with essential thrombocytosis who starts off with a hemoglobin level that's completely normal. And after about 6 years or so, the hemoglobin jumps up from 14 to 17. And they were able to show that what's happened here is that the activity of JAK2 has increased from a level of 28% to 52%. Why has that happened? That we don't know, but it's happened. The same thing goes with myelofibrosis. You have a patient with myelofibrosis with a low hemoglobin, and after a number of months, here it's a much shorter time period, the patient's hemoglobin suddenly increases only to decrease again. So I think these are very important slides sometimes to share with our patients, because at least in my experience, a lot of patients will be frustrated and confused by a changing diagnosis. They're first told they have ET, only to be told a couple of years later that they have PV, and sometimes vice versa. And sometimes myelofibrosis is then diagnosed as PV, and obviously vice versa. I think that all of this really indicates that we've still got a long way to travel along this road of MPNs and trying to understand precisely what's happening. And only when that happens, we'll be able to come along with more targeted and better drugs that can ultimately do better for our patients. Thank you very much for your attention.
Thank you very much, Martin. I'm very aware, obviously, that we're running over time a little bit. But the good thing is that Martin will be talking to you again a few more times this weekend. So if it's okay, we would like to hold any questions that you have for him until you see him again on the stage. So thanks again, Martin. Right, so my